Welcome to Module 2 Cervical Cancer. I'm Dr. Adlina, Family Medicine Specialist from Clinic Kesihatan Kulai. Today, we will discuss on cervical screening methods and how to manage the results. 1. Cytology method. Let's begin with the cytology methods used in cervical cancer screening. Conventional cytology, commonly known as the Pap smear, involves collecting cells from the cervix and spreading them directly on a glass slide. This method has been used for decades and remains a standard approach in many settings. Liquid-based cytology, or LBC, involves suspending cervical cells in a liquid medium before processing. LBC offers clearer slides, reduces unsatisfactory samples, and allows for HPV testing on the same specimen. DNA 2. Primary HPV DNA testing. Next, let's look at primary HPV DNA testing. This method detects the presence of high-risk human papillomavirus, the main cause of cervical cancer. Unlike cytology, it identifies women at risk before any abnormal cells appear, making it a highly sensitive method for early detection. It's now recommended as the primary screening tool in many international guidelines. With HPV testing, we can extend screening intervals and focus on those truly at risk. DNA 3. Co-testing. And finally, co-testing. This approach combines both cytology and HPV testing in a single screening. Co-testing improves detection rates by using the strengths of both methods. Often used in women aged 30 and above, especially in countries transitioning from Pap smears to HPV-based screening. It provides reassurance when both results are negative and helps clinicians decide the next steps if results are discordant. However, we do not practice co-testing in our Clinic Kesihatan settings. Screening Policy by Ministry of Health Malaysia, 2023. Cervical cancer screening is offered to all sexually active women. However, HPV testing is specifically recommended for sexually active women between the ages of 30 and 65. Women under 30 years of age can still undergo screening using cytology, either conventional Pap smear or liquid-based cytology. For women above 65 years of age who have never undergone any routine screening, HPV testing may still be offered. Stopwatch screening intervals. For women undergoing cytology screening, it begins with annual testing for the first 2 years. If both results are normal, they can then switch to cytology every 3 years. For women eligible for HPV testing, the recommended interval is every 5 years, as long as the result is negative. General advice prior to taking samples: LBC, HPV DNA, timing of screening. Cervical cancer screening should be avoided during menstruation. Blood can interfere with sample quality and test accuracy. Sexual activity. Patients should avoid sexual intercourse for at least 48 hours before the procedure. This helps ensure that the cervical environment remains undisturbed for accurate sample collection. Avoiding vaginal products. Patients should not douche or insert anything into the vagina, including medications, tampons, creams, or spermicides, for 48 hours prior to the test. These can alter the cervical cells or mask abnormal findings. Visible cervical lesions. If a lesion is visibly present during examination, it should not be ignored. Refer immediately to an O&G specialist for further evaluation. Screening is not sufficient in such cases. Postpartum consideration. For women who have recently given birth, screening should be delayed. Wait at least 6 weeks postpartum before performing the test to allow the cervix to heal. HPV DNA testing. HPV self-sampling kit can be in many forms. In Clinic Kesihatan, we provide flocked swab for our clients. HPV self-sampling. How to teach clients 1. Prepare the client. Explain the purpose of the test. We are testing for high-risk HPV, a common virus linked to cervical cancer. This is a safe and simple test you can do yourself. Ensure she meets the pre-test criteria: not menstruating, no sexual activity, douching, or vaginal products in the last 48 hours. 2. Explain the procedure. Use pamphlet or visual aid. Go through the steps slowly and clearly with the client. Tell her, You'll undress from the waist down and find a comfortable, private place provided. Open the test kit and remove the swab from the plastic tube. Hold the swab at the red line and gently insert it into the vagina up to that red line. Rotate it 10 times, then remove it carefully. Place the swab back into the tube and close it tightly. 3. Demonstrate using a sample kit. If available, show the kit and how to open the swab. Identify the red line. Insert and rotate correctly. Reinsert and seal the swab properly. 4. After the collection, remind client to return the sample tube to you. Record her name and sample number accurately. Let her know she will be contacted when the result is ready. Next, cytology testing. Cytology can detect abnormal changes in cervical cells before they turn into cancer. There are 2 main cytology methods: Pap smear and liquid-based cytology. There are several devices available for collecting a cervical sample. If an endocervical brush is not available, staff should use a cervical sampler broom, making sure the tip is positioned in the cervical os and rotated 3 to 5 times. Always ensure you collect enough cells from the cervix, including the transformation zone, and follow the manufacturer's instructions for the device used. Next, let's talk about the management of HPV results. The PCR test will report whether high-risk HPV types are present. Results are shown separately for HPV 16, HPV 18, and other high-risk types. Each will be reported as detected or not detected. If the sample is inadequate, the report will say unsatisfactory. For women with an unsatisfactory HPV test, repeat HPV test using liquid-based medium as soon as possible but not exceeding 12 weeks. The method follows the steps for taking a cervical smear using liquid-based, but the sample is sent for HPV test. This slide summarizes the management algorithm for HPV test results. Please take a moment to review the flowchart. Management of cytology results. If the smear result is unsatisfactory, the test should be repeated as soon as possible, and definitely within 3 months. For NILM results, normal, atrophic changes without inflammation, or absent transformation zone cells, continue routine screening. If infection or inflammation is found, treat, then repeat the smear within 6 months. Persistent changes require referral. Endometrial cells in women over 45, or glandular cells after hysterectomy, refer for further assessment. Remember, any woman with a suspicious cervix or persistent symptoms must be referred for colposcopy, regardless of results. This chart outlines the management of atypical squamous cell findings on cytology. If the result is ASCH, atypical squamous cells where high-grade changes can't be excluded, refer the woman directly for colposcopy. If the result is ASCUS, the next step depends on whether HPV testing is available. If HPV testing is available, a positive result means refer for colposcopy. A negative result means repeat HPV testing in 1 year. If HPV testing is not available, repeat cytology in 6 months. If the repeat still shows ASCUS, refer for colposcopy. If it's normal, return to routine screening. The goal here is to triage women appropriately, ensuring those at higher risk proceed quickly to further assessment. This chart shows how to manage women with LSIL cytology results. First, assess the woman for risk factors, such as being 30 years or older, poor compliance, immunocompromised status, symptoms, history of pre-invasive lesion, or positive for high-risk HPV. If any risk factor is present, proceed directly to colposcopy. If there are no risk factors, check if HPV testing is available. If HPV testing is available, a positive result means colposcopy and biopsy. A negative result means repeat cytology in 6 months. If HPV testing is not available, repeat cytology in 6 months. When repeating cytology, if the result is NILM, follow the NILM management pathway. If cytology is still abnormal, refer for colposcopy. The aim is to ensure high-risk women are referred promptly, while those at lower risk are monitored appropriately. This chart outlines the management of high-grade squamous abnormalities. If cytology shows high-grade squamous intraepithelial lesion, HSIL, or is suspicious for invasion, the woman should be referred promptly for colposcopy. If cytology shows squamous cell carcinoma, she should be referred directly to a gynecological oncologist for further assessment and treatment. The goal is to ensure rapid referral for early diagnosis and management of high-grade lesions or invasive disease. This chart shows the management of abnormal glandular cell findings on cytology. If the report shows atypical glandular cells, not otherwise specified, NOS, atypical glandular cells favor neoplastic, adenocarcinoma in situ, ASH, or adenocarcinoma, the next step is the same. Refer the woman to a gynecologist or a gynecological oncologist for further evaluation. These abnormalities require specialist assessment to confirm diagnosis and plan appropriate treatment. For women over 45 with endometrial cells on cytology, if no cervical abnormalities, do an endometrial biopsy. If cervical abnormalities are present, do an endometrial biopsy and manage the cervical findings as per guidelines. For pregnant ladies with abnormal cytology or CIN, please refer to gynecologist for further management. Screening in special population. Screening in pregnancy. WHO emphasizes that pregnancy is not the ideal time for taking cervical samples for cytology screening because it can give misleading results. However, if the patient is symptomatic, the standard screening and management should be followed. In contrast, in the group of patients who are unlikely to return after delivery, the healthcare provider may proceed with the cervical smear. Screening in immunocompromised population. High-risk immunocompromised clinical condition requiring more frequent screening includes all HIV-positive women, all women who had undergone solid organ transplant, SOT, all women with clinical conditions requiring them to take 2 or more immunocompromised medication. For immunocompromised women, cervical cancer screening is recommended for all who are sexually active. For women under 30 years old, use cervical cytology as the screening method. For women aged 30 years and above, use primary HPV screening every 3 years. If the HPV test is positive for any high-risk strain, refer directly for colposcopy rather than doing cytology triage. There is no age for exit. Screening continues for life in this group. For a deeper understanding, you can explore these recommended references for more detailed information. Thank you for listening. I hope you enjoyed the presentation and learned something useful. Wishing everyone a great day ahead.